Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Dawn, medical editor at MIMS Learning, and here with me is my colleague Pat, editor of MIMS Learning.
Hello.
Okay, so today we are turning our attention to respiratory conditions that a GP or another healthcare professional might see in primary care.
Yes, I enjoyed your interview with advanced nurse practitioner Bev Bostock about chronic respiratory conditions back in September. So did that prompt you to do some more on this topic?
Yeah, so something Bev said inspired me to sort of have another look at the issue, because she mentioned that while asthma and COPD tend to be the bread and butter of the respiratory conditions seen in primary care, people with a whole range of respiratory conditions will need some sort of support. So I thought, okay, let's have a look at those other respiratory conditions more in depth. Bev and I did talk briefly about bronchiectasis, so I thought we could start there.
We have a clinical review on bronchiectasis, which was recently updated by Dr. Fabiha Akhtar, Dr. Katie Hester and Professor Anthony de Souza. And they say it's a chronic disease resulting from the abnormal and permanent distortion of one or more of the bronchi. The airways are abnormally dilated and become a collecting point for excessive airway secretions. The epithelium is damaged, leading to loss of ciliated cells and impaired clearance of these secretions. And then the built-up mucus supports bacterial overgrowth in the airways, which results in recurrent and persistent respiratory tract infections. And these cause further inflammation, which then causes more damage to the bronchial walls in what the authors describe, unfortunately, as a vicious cycle of inflammation, damage and infection.
Apparently half of cases are idiopathic. That is, there's no identified underlying cause. However, there are some known causes. These range from bacterial respiratory tract infections like tuberculosis or TB to mechanical obstruction. There's also conditions that cause abnormal mucus clearance like cystic fibrosis. And spoiler alert, we will be talking about both TB and cystic fibrosis later in the episode.
And although we're not directly focusing on asthma or COPD here, both conditions are common comorbidities in people with bronchiectasis, but their exact role in causing the condition is still unclear. The module doesn't mention specific risk factors, but obviously smoking is a risk factor for any lung condition, and smoking inevitably makes any lung condition worse. For clarity, the information I'm about to pass on here relates to non-cystic fibrosis bronchiectasis. Bronchiectasis is characterised by chronic sputum production with susceptibility to lower respiratory tract infections. Chronic bacterial infections can cause daily purulent sputum production. And looking at other signs and symptoms, according to the module, patients often report feeling breathless on exertion and some experience chest discomfort. Many have associated symptoms of rhinosinusitis. However, while patients may report these symptoms, they may not be diagnosed for a while.
Okay, so I'm not medically trained, but I'm guessing this delayed diagnosis is because there's a lot of symptom overlap between bronchiectasis and COPD or asthma, which no doubt becomes even more of a problem if the patient already does have asthma or COPD. I checked this with the all-known guru, that is AI, and it told me that another reason why diagnosis takes a while is because bronchiectasis has historically been considered a rare condition. So GPs might not be thinking of it immediately when a patient presents with the symptoms.
Well, I think I want to take issue with AI there. Apparently 200,000 people in the UK have bronchiectasis, so it's not rare, and I'm surprised that AI says people thought it was.
Well, it can hallucinate, but it is very useful for answering the burning questions I had about the West Wing.
Well, right, okay, so maybe it's on safer ground there. But back to the delayed diagnosis point, I did come across a BMJ Open respiratory research study, which said that a survey of patients with bronchiectasis found that some felt their diagnosis had been delayed because of knowledge gaps amongst healthcare professionals, and they were more likely to feel this way than patients with other lung conditions. So here are some quick headline points that might help to fill any gaps. Though, of course, the best way is to go and read the whole module on MIMS Learning. Features of bronchiectasis that you might see on examination include finger clubbing, crackles heard over affected parts of the lung, nasal inflammation, an obstructive spirometry pattern, and as mentioned, purulent sputum. There's a really handy table in the module that lists points on clinical history, blood tests to conduct, imaging, and microbiological tests to conduct as well. And the module also goes into a fair bit of detail about diagnosis. For example, CT scanning should be used to confirm the condition, and thin slice high-res CT should be used for best diagnostic accuracy. And chest x-rays are an insensitive screening test for ruling in bronchiectasis, but they may be useful for ruling out other pulmonary conditions. The module also has information on determining the type and severity of bronchiectasis. For example, the cylindrical type is the most common of the 4 radiological types, and this runs a milder course and commonly affects the lower lobes bilaterally.
Determining type and severity is, of course, very important as this affects management. I think GPs would mostly be concerned with stable disease, but so the aim of management in people with stable disease is to alleviate symptoms, reduce the frequency of exacerbations, preserve lung function, and enhance overall quality of life. And obviously, where relevant, encouraging people to stop smoking is vital. Additionally, specialist chest physiotherapy input is essential. Patients should be assessed and guided in techniques such as the active cycle of breathing technique and the use of airway clearance devices.
The module also talks about pharmacological management, how to treat exacerbations, and when surgery can be considered. And there's a couple of case studies to put the information in context, so do take a look at the module. Let's move on. Dawn, you made a reference to cystic fibrosis before, and as you said, it's a major cause of bronchiectasis. And we also have a module on cystic fibrosis, so let's look at that next.
Sounds like a plan, Stan.
Okay, so cystic fibrosis is a common autosomal recessive disease affecting more than 10,000 people in the UK. And additionally, 1 in 25 people in the UK carry the gene responsible for the disease. While it has a higher prevalence in white Europeans, cystic fibrosis can occur in a person of any ethnicity. In fact, there are some concerns that it's seen as a disease that only affects white people, and as a result is underdiagnosed in people of other ethnicities.
That sounds very concerning. But some good news is that newborn babies born in the UK are now screened for cystic fibrosis by measuring the immunoreactive trypsinogen, or IRT, in the blood spot from a Guthrie test. IRT is a pancreatic enzyme that is elevated in the first days of life in a baby with CF. If the IRT is raised above the cutoff level, the newborn screening laboratory determines the genetic mutations in the blood sample using a panel of the 4 most common mutations. If this test indicates cystic fibrosis, a sweat test is performed. A sweat test is the gold standard test for cystic fibrosis. An abnormal result is a sweat chloride of more than 60 millimoles per litre. Prior to the introduction of this Guthrie test, people with cystic fibrosis were often diagnosed after repeated episodes of respiratory tract infections, persistent cystinuria, and failure to thrive. Now, infants diagnosed with cystic fibrosis through newborn screening are often clinically well at diagnosis.
So it's always good to hear about something improving, and that brings us on to CFTR modulators. These are, according to our module, which is by Dr. Ranjan Suri, small molecule drugs that bind to the cystic fibrosis transmembrane regulator protein with specific site affinity either during or after protein processing, and they can increase the amount of CFTR protein available at the cell surface. So these drugs have led to dramatically improved clinical outcomes in terms of lung function, frequency of chest infections, and maintaining weight. However, unfortunately, they can only be used in people with CF who have certain gene mutations, and therefore not all patients are eligible for them.
So in terms of other management options, as with bronchiectasis, chest physiotherapy is an important treatment. It needs to be performed on a daily basis, and the aim is to help patients clear the thickened secretions within their lungs. Antibiotics are given as a treatment for chest infections or exacerbations of pulmonary symptoms, such as increased cough. They are also given as prophylaxis, with many CF centres routinely commencing newly diagnosed infants with cystic fibrosis on antibiotics.
As well as cystic fibrosis being a cause of bronchiectasis, we also mentioned earlier that TB could be a cause. So let's talk about this next, because again, we have a clinical review on this, and this is by Dr. Kubra Boza and Dr. Julia Buckins. And at first glance, it does seem a bit out of place for MIMS Learning to have a module on this condition, given that we tend to view TB as an illness of times gone by. But actually, TB is on the rise in the UK. According to government figures, TB notification rates in England in 2023 increased by 11% compared with 2022. And while the UK for the moment is classed as a low incidence country, the module notes that increasing incidence of TB means the UK is further away from meeting the WHO target of a 90% reduction in people developing TB by 2035.
Yeah, I mean, that's very worrying. I actually commissioned the module on TB as part of our Targeting Health Inequalities campaign that we ran last year. The association between poverty and TB is very well known. In the UK, TB notification rates are much higher in the most deprived areas than they are in the least deprived areas. People who are socially excluded and who have overlapping risk factors for poor health, such as poverty, are disproportionately affected by TB. Socially excluded includes migrants. Migrants who are born in high incidence of TB countries, such as Bangladesh, are at increased risk. The risk of TB continues to be elevated among settled migrant communities. Overall, in 2022, people who are not born in the UK accounted for the majority of TB notifications in England.
So yes, unfortunately, TB is something GPs do need to be aware of. So let's quickly go over the presenting signs and symptoms, and these include chest pain, cough of more than 3 weeks, hemoptysis, and constitutional symptoms such as night sweats and fever. And although TB is seen as a respiratory condition, extrapulmonary TB can occur. And if a patient has extrapulmonary TB, this can make the diagnosis more challenging. So the module has a table on the types of extrapulmonary TB that can occur and their signs and symptoms. You might see signs and symptoms in the central nervous system, genitourinary tract, lymph nodes, bones, skin, pericardium, and gastrointestinal tract. And according to a conference report we published recently, abdominal TB accounts for about 5% of the 6,000 TB cases in the UK annually. And its symptoms can be very similar to inflammatory bowel disease, with bowel obstruction or perforation, strictures, and bleeding. So that's something to have on the radar as well.
And the module also has a lot of information on investigations to perform. But briefly, the key ones include bacterial culture, blood tests, chest x-ray, nucleic acid amplification tests, and sputum AFB smear. In terms of management, in a person with active TB, the aim is to cure and prevent transmission. Drug treatment should be over a period of at least 4 to 6 months and requires close monitoring of the patient's adherence, bloods, and side effects.
And you mentioned that that module was part of last year's Health Inequalities campaign. This year, as you may know from listening to podcasts, we've been running a campaign on earlier cancer diagnosis. And as part of this campaign, we have updated our module on the presentation of lung cancer. And of course, lung cancer is another respiratory condition that GPs need to be aware of. Like bronchiectasis, it's closely associated with smoking. And until recently, the incidence and mortality from lung cancer have been remaining stubbornly high. And the reasons for this high mortality are multifactorial, but they include late diagnosis, lifestyle, for example, smoking, older age at diagnosis, and socioeconomic disparities.
One of the reasons that lung cancer tends to be diagnosed late is that early stage lung cancer typically presents with no noticeable symptoms. To address this, the NHS lung cancer screening programme was introduced with the aim of earlier detection in high-risk individuals. The programme is offered to current or former smokers aged 55 to 74 years, and of course the smoking connection means they are high risk for developing lung cancer. Eligible patients undergo a lung health check, typically conducted by a specialist nurse. The nurse asks questions about any breathing or respiratory symptoms, family and medical history, lifestyle and smoking history. Based on the assessment, those identified at high risk may be referred for a low-dose CT scan. This scan provides detailed images of the lungs to identify any abnormalities.
And the programme's now active in 42 locations across England. And as of late 2024, more than 2.2 million invitations have been issued and about 1.1 million lung health checks have been completed. And importantly, around 6,000 lung cancers have been diagnosed at earlier stages. And of those diagnosed, 76% were at stage 1 or 2, where the disease is far more treatable. So that's really good news. A perhaps predictable consequence of this screening is that it's picking up other lung conditions such as COPD and bronchiectasis, which you might assume is a good thing, but sometimes the scans are picking up conditions when they're asymptomatic or not at a level that usually requires treatment. So that can present a bit of a dilemma regarding management. And respiratory GP, Dr. Steve Holmes, talked in more detail about this specific challenge in a podcast recorded earlier this year, and that's well worth a listen.
Okay, so we talked about bronchiectasis, cystic fibrosis, TB and lung cancer. Obviously, there are other respiratory conditions we could talk about, but hey, we've got to leave some material for future podcasts, haven't we? But I'm conscious that we have not yet mentioned flu. And there are currently concerns that we are heading towards a severe flu season and a season that has started earlier than expected. Such is the concern about this year's flu season that the UK Health Security Agency and the Department of Health have sent out an alert to remind clinicians of the importance of promoting and delivering the flu vaccine for eligible patients and for healthcare workers. Our sister website, MIMS, has some good resources on this year's vaccines. There's a table summarising the composition of each vaccine, along with information on routes of administration, licensed age range, price and manufacturer, and another one that presents the recommended vaccine options for each age group.
Yes, and don't forget that if you subscribe to MIMS Learning, you can also access MIMS content and vice versa.
Thanks for that, Pat, and thanks for joining me today. Okay, so what have we learnt? Bronchiectasis is a chronic disease resulting from the abnormal and permanent distortion of one or more of the bronchi. It is characterised by chronic sputum production with susceptibility to lower respiratory tract infections. Features of bronchiectasis that you might see on examination include finger clubbing, crackles heard over the affected part of the lung, nasal inflammation, an obstructive respiratory pattern, and, as mentioned, purulent sputum. Things have improved with cystic fibrosis. Now infants are diagnosed with newborn screening and are often clinically well diagnosed. Prior to the introduction of screening, people with cystic fibrosis were often diagnosed after repeated episodes of respiratory tract infections. Additionally, CFTR modulators have led to dramatically improved clinical outcomes such as lung function, frequency of chest infections and weight. However, unfortunately, they can only be used in people with CF who have certain gene mutations, and therefore not all patients are eligible for them. The NHS Lung Cancer Screening Programme is now active in 42 locations across England. As of late 2024, more than 2 million invitations have been issued and 1 million lung health checks have been performed. And importantly, around 6,000 lung cancers have been diagnosed at earlier stages. Of those diagnosed, the majority were diagnosed at stage 1 or 2 when the disease is far more treatable. A predictable consequence of this screening is that it's picking up other lung conditions such as COPD or bronchiectasis, which you might assume was a good thing. But sometimes the scans are picking up conditions when they are asymptomatic and or not at a level that usually requires treatment. So that can present a bit of a dilemma regarding how to treat such patients. Thank you for joining us today. Don't forget you can claim CPD credits for listening to these podcasts, and there are plenty more on the MIMS Learning website. We have been the MIMS Learning editorial team, and this episode was produced by Jude Owen.